And as she mentioned, I will start the session with antibiotics in theory and practice, antibiotic theory in practice. And I would encourage all of you to be interactive. We will try to keep time for questions. The panel discussions are also fashioned in a way that hopefully we should encourage some interaction. And we would appreciate your comments and suggestions as to how we can improve this program, or any specific topics you would like to be included for maybe the next year's session. Right, I shall be talking to you about antibiotics. I have written as theory and practice. And I'm not sure if all of you will be able to see the punchline in the cartoon. The kid is asking the mother, gee mom, if he got all these from medical schools, why is he still practicing? As doctors, how many years ever we study, we still practice medicine. We are not proficient in doing it as a work, so it's still referred to as practice. And nothing can be more true with regard to the use of antibiotics. In spite of using antibiotics in our daily practice, we still have a lot of confusions and worries whether we are doing the right thing. There are some common misconceptions amongst doctors. Purulent secretions indicate a bacterial infection. Purulence refers to presence of white cells, which can happen with viral infections also. So if somebody has a sore throat and brings up green sputum, that doesn't mean that he has a bacterial infection. It can still be viral. Antibiotics are needed in viral infections to prevent bacterial superinfection. Viral infections are all short-lived. So if an infection lasts more than 3 to 5 days, then it requires antibiotics. A sore throat requires antibiotics because it may evolve or be a harbinger of something serious, and a lesser antibiotic dose suffices for milder infections. But the problem is not that we don't know the answers. The problem is we don't sometimes understand the questions. So if we get our questions or ask ourselves the right questions, we will definitely be able to come up with the right answers, because theoretically I think we are all very, very sound. So I'm going to start with some antibiotic essentials. First, the spectrum of antibiotics. In general, I will stick to the broad classification of gram-positive organisms and gram-negative organisms. Gram-positive organisms are covered by antibiotics given on the left side of the screen, mainly first-generation cephalosporins. Sporidex, or if you want parenteral, it is cefazolin. Clindamycin is a very good antibiotic for gram-positive infections, and it also covers anaerobic organisms. It does not have any action against gram-negatives. Cloxacillin is a gram-positive beta-lactam agent, which is specific for Staphylococcus. If you move down, you have glycopeptides, mainly composing of vancomycin and teicoplanin, which are also specific for gram-positive infections. They do not have any gram-negative cover. Daptomycin, a newer agent, again for resistant gram-positives, mainly MRSA and enterococci, and linezolid, which we often use, should actually be reserved only for resistant gram-positive organisms. Amongst gram-negative spectrum of drugs, we have third-generation cephalosporins. When you move down the first to third generation cephalosporins, it moves slowly from a gram-positive cover to a gram-negative. So cefotaxime, cefoperazone, ceftazidime, ceftriaxone have a more predominant gram-negative coverage. Aztreonam is a drug which has properties very similar to ceftazidime. So it's a monobactam which covers mainly gram-negative organisms. We have a higher beta-lactams, piperacillin and ticarcillin, which are again used more for gram-negative side of organisms. We have beta-lactamase inhibitors like cefoperazone, sulbactam, or piperacillin, tazobactam, which are more useful for treating extended spectrum beta-lactamase producing organisms, what we call as ESBL. We have carbapenems, which have a very good spectrum, more on the gram-negative side, and polymyxins, that is colistin and polymyxin, which are now being used for treating carbapenem-resistant organisms. Quinolones have a wonderful spectrum. There are up to 4th generation quinolones, starting more from the gram-negative and spreading to the gram-positive side. In fact, the newer quinolones have certain MRSA activity also, but unfortunately in India, because of extensive use, the resistance is so high that they are not of practical relevance. So you have to use quinolones only if you know that it is sensitive and it will work. Macrolides and tetracyclines, they are more useful to cover atypical organisms. It can include atypical pneumonia-causing organisms like Legionella, Mycoplasma, Chlamydia, or also organisms like scrub typhus, Rickettsia are very usefully covered with tetracyclines. We need to understand that when you talk about antibiotics, the antibiotic may be the right antibiotic, it may cover the bug, but does it reach the tissue where it is supposed to act? So the tissue penetration depends on whether the antibiotic is lipophilic or hydrophilic. In general, hydrophilic antibiotics reach very good levels in the circulation. So all your beta-lactams, they will reach good levels in circulation, whereas lipophilic antibiotics, which concentrate more in the tissue and in the lipid stores, like tetracycline, tigecycline, they are all antibiotics which have a higher concentration in the tissue than in the vascular compartment. We also need to understand antibiotics may have difficulty in penetrating into certain areas, especially, for example, where there is an abscess. Unless you drain the abscess, antibiotics will not work. If there is a low pH or acidity in that area, certain antibiotics like aminoglycosides may not be effective. In device-associated infections, whether it is a prosthetic joint or a prosthetic valve, because of the formation of biofilms, which refers to a slime-like layer which forms like what we call a sparsy, on the prosthetic material, quite often it is very difficult to eradicate completely the infection unless the prosthesis is removed. We also need to keep in mind the safety profile of the organisms. Now coming to resistance to antibiotics can be two types. It can be either an intrinsic resistance or an acquired resistance. Intrinsic resistance, for example, because of the structure of the organism. For example, the outer membrane in the gram-negative bacteria give it certain importance. It could also be to the presence of certain pumps which may pump out the antibiotic intrinsically. For example, all enterococci are intrinsically resistant to cephalosporins. The acquired resistance is when you expose the antibiotic to a bug and the bug keeps on mutating. The one which is very conducive to grow in the presence of the antibiotic, what we call a survival of the fittest, grows up. So the mutated organisms which now has ability to grow in spite of the bacteria, that shows resistance, that is an acquired resistance. This resistance mechanism can be transmitted between various bacteria through plasmids. So it can be either chromosomal resistance transmission or transmission through plasmids. Please remember that most acquired resistance is agent specific, not class related. So if it is resistant to gentamicin, it need not be resistant to amikacin. Amikacin may still work. If it is resistant to ciprofloxacin, it is possible you may still be effective by using levofloxacin or gatifloxacin. You also need to understand that antibiotics sometimes can induce resistance. Drugs like ciprofloxacin, imipenem, gentamicin, they can all cause a higher propensity for resistance to develop when compared to using amikacin. In spite of using amikacin for 10 years, amikacin resistance is not as easy to develop as if you had used gentamicin. Similarly, levofloxacin has a lesser tendency to promote resistance. Meropenem has a lesser propensity to promote resistance. Mode of elimination does not predispose to excretion or excretory organ toxicity. Example, normally when we say it is excreted through the kidney, we tend to believe it may be nephrotoxic, not necessarily. Nafcillin, an antibiotic which is not currently available, is actually excreted through the liver, but it can, excreted through the kidney, but it can have hepatotoxicity, whereas oxacillin, which is the other way around, can cause interstitial nephritis. This is an example of some organisms. I am afraid, I don't think again people in the back may be able to see, but highlights the natural resistance of various drugs to various bugs to various drugs. Organisms like Pseudomonas or Klebsiella or Proteus or Serraceae may not be actively treated by ampicillin, amoxicillin and first generation penicillins because they are inherently resistant. Burkholderia, for example, even Burkholderia pseudomallei, which causes melioidosis, will not respond to amoxicillin, ampicillin, aminoglycosides, or even colistin. Steanotrophomonas, a highly resistant hospital-acquired bug, will not respond to carbapenems. Salmonella, even if the report shows that it is sensitive to cefuroxime or aminoglycosides in vitro, in vivo it may not work. So don't use cefuroxime or aminoglycosides in treating enteric fevers. Enterococci, as I said, may be resistant to all cephalosporins. We also need to understand how a drug acts to optimize its use. When you give an antibiotic, the level of the antibiotic increases in the circulation, reaches a high concentration then subsequently declines. Drugs like aminoglycosides act by a concentration dependent fashion. So you need to give a dose which reaches a very high level, and subsequently if the level goes below the level of the MIC, which is the line parallel to the x-axis, even if it goes below that level, the drug still works because of a post-antibiotic effect. So that is the reason why all aminoglycosides should be given preferably once a day. If it is gentamicin, you calculate 3 to 5 milligrams per kilogram per day and give it as one dose. So there is no harm in giving 240 milligrams of gentamicin as a single dose once a day rather than 80 milligrams 3 times a day. Amikacin, 1 gram once a day is better than giving 500 milligrams twice a day. But there are certain other drugs, mainly the time-dependent drugs. Time-dependent action is seen predominantly by beta-lactam agents. So penicillins and cephalosporins may act by a time-dependent fashion. So this is the MIC. So the time-dependent action is by beta-lactam. So you need to keep the antibiotic consistently above this level. If it goes below the MIC, it will not work, which means you may have to give the drug repeatedly. Instead of once a day, you may have to give it 4 times a day. Or sometimes in the hospital, in the ICU, we tend to give it as an extended infusion. So we give, for example, meropenem as over 3 hours every 8th hourly. Or we tend to give, for example, crystalline penicillin, which is very stable in room temperature, can be put in one bottle of 500 ml of 5% of normal saline and let it run over 24 hours so that you keep a level consistently above the MIC to treat severe meningeal infections. So by understanding how the antibiotic acts, we may be able to optimize the use. We also need to understand that adequate dose of antibiotics is essential. My common example, which I often give is, let us take the example of piperacillin tazobactam. The dose recommended is 4.5 grams 4 times a day. But a lot of us use 4.5 grams twice a day, and it still works because it reaches concentration above the MIC and it stays at this level. So this level, it will still work, but this is what is called the mutant selection window. So if the drug is at this level, there is a possibility of mutations to develop. What you need to reach is at this level where mutations are very, very minimized and mutations don't happen. So when you use piperacillin tazobactam twice a day, it will work for that patient. But after a few months or years, inevitably the antibiotic will not work because of development of mutants. So please remember to use the adequate dose of antibiotics. What about in renal failure? We need to understand, for example, in patients on hemodialysis, irrespective of what the creatinine is, the loading dose remains the same. So if you're using a parenteral antibiotic, the first dose always remains the same. If a person comes to you in septic shock, you don't know whether he has renal failure, go ahead and give the first dose of whatever antibiotic to give, whether it is aminoglycosides, whether it is vancomycin, whether it is penicillins, the loading dose remains the same. Subsequently, once you get the creatinine, you modify the dose. You can decrease the maintenance dose or you can increase the dosing interval. Any one is feasible, and some antibiotics need a subsequently post-hemodialysis dose may be indicated. Please remember, now we are doing a lot of CRRT, continuous renal replacement therapy, which is a slow filtration which is done in the ICU for patients who are severely ill. Please remember that these patients will have, technically speaking, a low creatinine clearance, which means you may think that you may need to reduce the dose. But the CRRT process, the filtration in the membrane, actually removes the antibiotic also. So sometimes you may need to give the normal or sometimes even higher dose of antibiotic than normally in patients in renal failure who are on CRRT. We don't have a specific algorithm to modify doses for patients with liver failure, but at least those antibiotics which are processed through the liver, the doses may need to be reduced. A few words on microbiology and susceptibility testing. Please remember that in vitro data does not differentiate between colonizers and pathogens. There is no test under the sun which will help differentiate a colonizer from a pathogen. So if you take a swab from an ulcer and it grows a bacteria, nobody can tell you that is a bacteria sitting on the surface of the ulcer just keeping quiet, or it is the bacteria causing the infection against which you need to use an antibiotic. In vitro susceptibility does not always predict in vivo effectiveness. What you are doing is in the lab. The drug will act very well against the bug, but whether the same drug will work in the human may depend on, like I said, whether the infection is, where the site of the infection, the pH of that area, the blood supply to the area, the presence of foreign body, all that has to be taken into consideration. In vitro testing is dependent on the microbe, the methodology, the pH and the antibiotic concentration. So always be careful that whatever the microbiology lab gives is what is seen in the lab, may not be completely extrapolated to the human body. And in vitro susceptibility testing assumes that the isolate was recovered from blood, which means there is a possibility for certain urinary tract pathogens. The in vitro test may be resistant, But in the body, there is a very high level of antibiotics through the urine which may be excreted, especially aminoglycosides or quinolones, which may actually be effective. So sometimes you'll be surprised that even resistant drugs may work depending on the site of the infection. There are issues regarding bactericidal and bacteriostatic, which we have read in microbiology, but in real life treating patients, there is usually no reason to worry about whether this drug is bactericidal, I have to use only this drug, I shouldn't use bacteriostatic, except for maybe a couple of situations like infective endocarditis and meningitis. For most other infections, bacteriostatic or bactericidal doesn't matter. There is enough evidence now to show that unless you need to use combination therapy to cover a wider spectrum of organisms, polymicrobial infections, gram-positive, gram-negative, you don't know, when you use a combination, for all other situations, monotherapy suffices or actually is better than combination therapy, which may have added side effects. Also, please look into changing from intravenous to oral at the earliest possibility when the person is able to eat well and his blood pressure is maintained, especially with antibiotics which have a good bioavailability so that the cost can be reduced. We now resort to more and more of what is called OPAT or outpatient antibiotic treatment. Examples will include somebody with a pyelonephritis who may require 2 weeks of antibiotics parenterally. Patient gets admitted to the hospital. After 3-4 days, he is very well, but you need to continue the antibiotics for 2 weeks. We don't keep them in hospital. We put a long line or a pick line, send them home so that they can get once a day treatment either through a nurse or comes to the hospital or nursing home and has it once a day. This will lead to tremendous savings for the patient because you don't need to keep a good, fine patient in the hospital for 10 days just because he requires IV treatment. Lastly, there is a trend towards more and more shorter courses of therapy, except for certain specific infections like endocarditis or chronic osteomyelitis or certain other infections, as I said, for pyelonephritis, where you need to give 2 weeks. Most other infections, we are now resorting to a shorter course of treatment. A few words on drug fever. Please remember that drug fever is unfortunately a diagnosis of exclusion. It is quite often seen in patients who have atopy. The range of fever may be actually high, 104, 103, they may manifest such high fevers, and they may have relative bradycardia. With a temperature of 104, their pulse rate may be only about 90 or so. The classical clue is they are inappropriately well. So a person may have a temperature of 103, but sometimes says, I didn't even know that I had fever. Only when the nurse told me I realized I had fever. They may have a raised white cell count, high eosinophil count and a high ESR and a mild transaminase also and a negative blood culture. Usually you stop the medicine within 3 days, the person responds. That is the only way to diagnose. Antibiotic failure can be due to several reasons. Microbiological factors like in vitro is sensitive but ineffective in vivo, or you could be treating a colonizer. It could be antibiotic factors related to poor spectrum, inadequate tissue levels, poor activity in the tissue, and also due to drug-drug interactions. Problems of penetration, especially if it is an abscess or presence of a foreign body or due to biofilm. Non-infectious causes like SLE, malignancy, drug fever. And lastly, unresponsive because it is not a bacterial infection, viral or fungal, or sometimes you are just too late when you initiate an antibiotic. Now I'm going to have an interactive session for 3 or 4 cases to encourage you to come up with some thoughts on this. A 37-year-old male, a non-diabetic, presents with multiple boils all over his body, who complains of recurrent lesions like this. He has an IND done twice in the past, and this is his culture report. The culture report shows that there is Staph aureus growing, and unfortunately, the result doesn't tell us whether it is sensitive or resistant. It only tells us zone diameter and interpretation of 3 pluses, 2 pluses, or 1 plus. So how do you interpret this? It is very difficult because zone diameters, unless the laboratory tells it is sensitive or resistant, you cannot interpret it. To give you an example, penicillin, for example, it may appear that penicillin seems very susceptible because there are 3 pluses, but penicillin, unless it is more than 29, it is not sensitive. So please don't make your own conclusions with the report. You need to get the lab report. So which means penicillin is resistant, piperacillin, erythromycin, gentamicin is resistant. What about the others? Whenever you find Staphylococcus aureus, the first question you need to ask is it MSSA or MRSA, which is methicillin sensitive or methicillin resistant? Usually we depend on oxacillin for that, but the recent CLSI guidelines say that oxacillin disc is unreliable and you have to use only a cefoxitin disc. Unfortunately, cefoxitin disc is not routinely done in all laboratories in India. So this is a clue to keep this in mind. So based on whether it is sensitive to cefoxitin, it is MSSA. If it is resistant, it is MRSA. Otherwise, a rough rule of thumb would be oxacillin, cloxacillin, or methicillin. If the lab gives any of them and it is resistant, then you take it as MRSA. So to differentiate, you need to check between cefoxitin sensitivity or not. Please remember that if it is penicillin resistant, ampicillin, piperacillin won't work. It may be sensitive to clindamycin, but if it is sensitive to clindamycin, before you use clindamycin, see whether it is susceptible to erythromycin or not. Because if it is resistant to erythromycin and susceptible to clindamycin, there may be cross-reactivity, cross-resistance transmission, and it may not, clindamycin may not work. So before you write clinda, check whether it is sensitive to erythro. If it is MRSA, the choice of therapy would be vancomycin, teicoplanin, or linezolid. If it is MSSA, it will be either cloxacillin or cefazolin or even clindamycin. Please remember, ceftazidime, cefixime, and ciprofloxacin are not optimal drugs for Staphylococcus, and for MSSA, clox is superior to cefazolin, is superior to vancomycin. So even though vancomycin will work against both MRSA and MSSA, please do not use vancomycin if it is an MSSA because it is inferior to cloxacillin or cefazolin. What will you do if the blood culture grows Staphylococcus? Which antibiotic will you use? If the blood culture grows Staph, cloxacillin would be the drug of choice if it is MSSA. Vancomycin would be the choice if it is MRSA. That's the rule of thumb. In general, linezolid can be used if there is a secondary bacteremia. So if there is either a pneumonia or a surgical site infection or a tissue infection which secondarily causes MRSA bacteremia, you can use linezolid. Clindamycin is a very poor agent to use for bacteremias. So do not use clindamycin for bacteremia. Daptomycin can be used, but it is very expensive. The third case, a 55-year-old diabetic lady who presents to the emergency department with septic shock, and you presume it is urosepsis. The person has had a history of dysuria, frequency, and maybe flank pain. She has normal renal functions. The urine shows plenty of pus cells. The urine culture grows more than 10 to the power 5 colonies of Proteus. So this seems a reasonable, straightforward case of urosepsis. And this is the report. Proteus grown. The result is given as susceptible to ampicillin, cefalexin, nitrofurantoin, cefazolin, tetracycline, chloramphenicol, nalidixic acid, but resistant to norfloxacin and ciprofloxacin, susceptible to GATI and ceftriaxone. So at the outset, it looks like a very simple, susceptible Proteus vulgaris. So what would our tendency be? What antibiotic would you start?
Was she on any antibiotics?
No, she was not on any antibiotics before.
In this case, ampicillin.
Ampicillin. That will be the normal, let us keep the antibiotics simple. You give IV ampicillin. But is that the right one? The options given actually are coamoxiclav, tigecycline, cefazolin, ceftriaxone, ciprofloxacin. Okay? I'll come back to this in a minute. The first thing is, as I told you, intrinsic resistance. And most GNB, especially Proteus, Serratia, Providentia, are all resistant to penicillins and aminopenicillins, which means you cannot use ampicillin or coamoxiclav if it is Proteus. That is why you need to know the species, before the genus at least, before you decide what is to be used. The second question, which means ampicillin, cefalexin, nitrofurantoin, cefazolin, all will not work, so they are not good actions. This one gives the answer. Proteus, Providentia, Serratia are resistant to ampi and first generation cephalosporins. Proteus are also inherently resistant to nitrofurantoin and tetracycline. Nalidixic acid sensitivity predicts susceptibility. Please remember, nalidixic acid is a first generation fluoroquinolone. So this one, surprisingly, it says nalidixic acid susceptible, but says ciprofloxacin and norfloxacin resistant. So that doesn't fit. So one of them is wrong. So normally, if it is nalidixic acid susceptible, you can boldly use other quinolones. And chloramphenicol does not achieve adequate levels in the urinary tract. You also see that Proteus will not work, tetracyclines or tigecyclines will not work for Proteus. These are inherent. So when you look at gram negatives, E. coli and Klebsiella are different, but as you go down into Proteus, Serratia, Providentia, you find that they have a little more, ego than the others. So in this case, probably I told you coamoxiclav you cannot use. Tigecycline, which is a tetracycline derivative, doesn't work. Cefazolin will not work. Ciprofloxacin, we are not sure because nalidixic acid is susceptible, but ciprofloxacin was given as resistant. Ceftriaxone is an acceptable drug. So the reason why I'm putting this up is you may know your antibiotics or you may have a sensitivity report. Still, you may need to use a little, input to decide whether what is given in the report is the correct one to use. Yes, sir.
Had at least 1 incident of sepsis previously before that.
No, sir. She was a new case which came. Which one, sir? We didn't have the susceptibility for cotrimoxazole. That's why we don't know. But otherwise, but since she came in sepsis, now if you get the IV cotrimoxazole, it can be used. Sorry, sir?
Cost factor you must see.
Yes, yes. But ceftriaxone is 100 rupees a day, so I think that's fine.
Ceftazone sulfactam.
Sorry?
Ceftazone sulfactam.
Cefoperazone sulbactam, again, we don't have the susceptibilities, but I presume it will definitely work, so it can be used. Amikacin was not given. If amikacin is susceptible, you can use amikacin. 65-year-old male, hypertensive, diabetic, coronary artery disease, chronic kidney disease with a creatinine of 2.4, admitted with fever and altered sensorium, and also has urinary incontinence. So this is also looking at, there is a possibility this could be a urinary infection. The blood culture now again shows proteus, and now you have the interpretation, piperacillin resistant, cefuroxime resistant. It is susceptible to cefotaxime, but resistant to ceftazidime, and resistant to a lot of others, and susceptible to carbapenems. What would you choose? In general, any bug which is resistant to third generation cephalosporins is an ESBL producing organism, extended spectrum beta lactamase producing organism. So if one third generation cephalosporin will not work, the practical rule of thumb is don't use third generation cephalosporins. Cefotaxime and ceftazidime both are third generation cephalosporins. It is mentioned that this is susceptible, this is resistant. So I would take this straight away as an ESBL. This is just like I said, not all labs will be able to give you all the information, but this will be simple test. If you have a gram negative resistant to any third generation cephalosporin, don't use any other third generation cephalosporin, because assume it is an ESBL producing organism. Okay? Yes, sir.
CKD. Chronic kidney disease.
Yes, sir.
Serum take is almost stable, 2.10.
We don't know whether it is stable, but it is 2.4 before he came.
Renal clearance also in this case.
No, I am asking about the choice of the drug, sir. The dose, all that will come subsequently. The choice of the drug is what I'm asking. So the options given are cefotaxime, nitrofurantoin, cefoperazone, sulbactam, imipenem, colistin. Cefotaxime, as I said, is not a good idea to use. Nitrofurantoin seems acceptable, but please remember nitrofurantoin is completely excreted through the kidney, and when you have a creatinine of 2.4, nitrofurantoin is not a good choice because it doesn't get into the urine at all, so it doesn't treat a urinary infection. Cefoperazone, sulbactam, yes, can be used. Imipenem, yes, can be used. Colistin, again, you have to, because it is proteus, it may not be susceptible.
Colistin has been already accorded in find mentioned at the bottom of list of antibiotic. You must use.
In the sick hospital patients who are usually having carbapenem resistant infections, we use, not generally as an outpatient treatment.
Last choice.
Yeah. The last case, a 76-year-old diabetic with a CVA, time's up, who's bedridden, indwelling folies, pressure sores, admitted with altered sensorium. Now this is his culture report. You have got a urine culture which shows E. coli, a pressure sore which goes Staphylococcus aureus, and I'll help you, this Staph aureus, this one says resistant to clox, so I would presume this is an ESBL. It is susceptible to Clinda, but this doesn't give erythromycin. And E. coli, which is resistant to cefotaxime, so I would place it as an ESBL. It is intermediate to cefoperazone sulbactam, so this may not work. So probably carbapenem would be the drug of choice, right? So the natural tendency to would choose probably meropenem plus vancomycin. Is that acceptable, or linezolid? But please remember, the reason I put this up is, this is a 76-year-old diabetic who has pressure sores and who has an indwelling folies. Now, anybody with an indwelling folie, it is a matter of time before he grows a bacteria. So please doesn't mean that the bacteria in the urine is causing a problem. Similarly, when you take a swab from a pressure sore, inevitably it may be colonized. So both of them may not be the reason why he's having fever. So this case is only to stimulate you to think that don't immediately react to a microbiology report. Please think whether these are actually significant in the patient. For all you know, he may have a pneumonia. So evaluate a patient, don't jump into looking at the microbiology report. A quick word on antibiotic stewardship before I conclude. This is the way forward. Now there is a big trend towards antibiotic stewardship because we are having a rising resistance and we are having very poor antibiotic availability because there are no new antibiotics. So stewardship refers to a group of interventions to optimize antibiotic usage. This is based on the antibiogram which is available in your locality, which tells you which are the normal drugs which may be working and which may not work. The susceptibility and the resistant pattern. You need to have a surveillance of the infections. You need to have in your hospital, if you have an antibiotic policy, what somebody does in Apollo may not be relevant to what somebody does in Tandayarpet. Similarly, what somebody does in the US and gives guidelines may not be applicable to India. You need to educate people, ensure that cultures are sent before antibiotic is utilized, monitor antibiotic use, and also audit. This is very important because collateral damage, which refers to the unintended consequences. If I use an antihypertensive or an anti-diabetic, it does not have any consequences on anybody other than the patient on whom I use. But when I use an antibiotic, it alters this flora. This bacteria can get into the sewage, can contaminate, and can affect the whole society. So please remember, the antibiotic I use on one person has consequences on the entire society. So before you write antibiotics, please think twice, thrice, 10 times before you write an antibiotic. Thank you.
I heard one speaker telling the audience one day in a conference, he said, antibiotics used for prophylaxis can't be used for therapy and vice versa. He replied, "We need as a long-standing practice